about the basics of the diabetes. Now we'll move on to the diagnosis and the classification of the diabetes. So this is the diagnostic criteria. You all know that 4 values: fasting more than 126, postprandial more than 200, random more than 200 plus symptoms, and then the HbA1c more than 6.5. So these are any one of the criteria, 4 criteria is sufficient to diagnose a person as a diabetic individual. So here, why fasting only 126, why not 125 or 130? Because at this level, the retinal changes starts appearing. So the retinopathy starts once the fasting blood sugar is at 126 or beyond the 126. That is how the number 126 has come into the existence as far as the fasting blood sugars are concerned. Here, a male asymptomatic 32-year-old, fasting 138. His father has type 2 diabetes. His BMI is 24. So what is your working diagnosis? So is he a diabetic or not? Yes. The fasting is more than 126 is a diabetic. He is a diabetic. So is it type 1 diabetes or type 2 diabetes? Mostly type 2 diabetes, because type 2 diabetes runs in the families. A strong family is there. And the third important point to say this is the type 2 diabetes is his BMI. So what is his BMI? Is it normal BMI or overweight or obese? Not normal. Good, overweight. For Asians and Indians, the normal BMI is 23 only. So 23 to 24.9, it is overweight, and 25 and more than 25 is obese. So do you need any other test to confirm the diagnosis? For confirmation, not required. Already is a type 2 diabetes. But to initiate on the medical management, to understand what is the nature of the diabetes and what is the control of the diabetes, what is the gravity of the diabetes, definitely you need other investigations like HbA1c. Suppose here the HbA1c is 11.5. That shows he is a chronic diabetic of more than say 9 years or 9 months or the 1 year, etc. Suppose his BMI is 6.6. That means most recently entered into the diabetic range. So all these years he is pre-diabetic. Just for the last 1 month or 1 month or 2 months or 3 months, he has become the diabetic. So depending on that, you can prescribe the medication. Suppose the newly diagnosed diabetic, I don't think that you require medication at this juncture. Medication, I mean to say that the insulin or the OHS. So just with your lifestyle measures, the role of the diet, the role of the exercise, the role of the yoga, the role of the meditation, the role of cessation of the smoking, the role of increased fiber, the role of lowered. So definitely you can make this fasting blood sugar around 100 or 110 within 2 months or 3 months of the dietary restrictions. This is another case, female, 48 years, BMI is 32, no family history of the diabetes. She complains of weight loss, polyuria, polydipsia for the last 6 months. Her casual plasma glucose is 335. So what is your working diagnosis here? So two things here. One is diabetes, because the random blood sugar, the casual blood sugar means random blood sugar, it is 335. So random more than 200 with symptoms, symptomatic, is always a diabetic. Okay, then number 2, obesity. BMI is very high, 32. So 32 is definitely obesity. Okay, diabetes plus obesity, diabesity. Is it type 1 diabetes or type 2 diabetes? No family history. So still it is a type 2 diabetes because she is from India. So when the mother is having the diabetes, there is about 48% chances. If the father is a diabetic, maybe 39 or 40% of the chances. Both are the diabetics, maybe 60% of the chances. If there is no family history, still 25% chances because you are an Indian, you are an Asian. So Indian genes and Asian genes are more prone for the diabetes. So even though there is no family history, but she is obese, she is diabetic, she is symptomatic, So 100% it is type 2 diabetes. Type 2 diabetes. Do you need any other test to confirm the diagnosis? For confirmation of the diagnosis, don't require it. But for further management, you require it. So here the random is 325. What about the fasting? Is it 150 or 200 or 250? What about the postprandial? Is it 350 or 400 or 500? What about the HbA1c? Okay, is it 6 or 7 or 8 or 10 or 12, etc.? Whatever the lipid profile, she's obesity is there, so lipid profile. Whatever the triglycerides, any isolated hypertriglyceridemia, etc. So whatever the thyroid profile, she's a female, obese, diabetes. Whatever the hypothyroidism, rule out the hypothyroidism here. Okay, so all these things are very much needed. So some people, 40% of the diabetics, they will be having the complications even at the time of the diagnosis itself. So whatever the retina, to rule out the retinopathy, whatever the microalbuminuria, to rule out the nephropathy, and then the monofilament examination to rule out the neuropathies, maybe in X-ray, maybe in ECG, maybe 2D echo, etc. to rule out your left ventricular hypertrophy or asymptomatic cardiovascular disease. So these are all very much needed in this patient because female, perimenopausal, obese, and also high blood sugars. High blood sugars. So the pre-diabetes is nothing but the values between the normal and the diabetes. You know the diabetic values. Tell me the normal values. What is the normal fasting blood sugar? Less than 100. Less than 100. 110 for the Western population. For Indians, it is 100. What is the normal postprandial blood sugar? Less than 140. 140. So the fasting less than 100, postprandial less than 140, they are the normal values. Now you know the values of the pre-diabetes. So the fasting between 101 to 125 is impaired fasting glucose or pre-diabetes. The postprandial blood sugar between 141 and 199 is impaired glucose tolerance or the pre-diabetes. So this is a very big topic for you, pre-diabetes. Pre-diabetes means the fasting blood sugar between 101 to 125, postprandial blood sugar between 141 to 199. So why you give respect to the pre-diabetes? Because see, this pre-diabetes is also equally responsible for atherosclerotic events, for your ischemic heart disease, for coronary artery disease, for CVA, for peripheral vascular disease, for your fatty liver, for your PCOD, etc. and etc. So the pre-diabetes itself is an independent risk factor for the vascular diseases. So you have to treat the pre-diabetes also, not with the medication, but with your non-lifestyle measures, And of course, some people, they may require a drug also to reduce the pre-diabetes. High risk individuals, the hypertension is pre-hypertension, the cholesterol is much higher, the patient is obese, the person is obese, with a strong family history, early cardiac deaths in the family, he is also a smoker. So don't leave the pre-diabetes. Give prescription. What drug you prescribe for pre-diabetes? It is not sulfonylureas, it is not the gliptins, they are not the SGLT inhibitors, but starts with letter M, metformin. So you can start the metformin in a selected cases of the pre-diabetes, provided if the person is at high risk of getting the ischemic heart disease or vascular events in the near future. Otherwise, you need not prescribe any drug to the pre-diabetes. 99% we don't prescribe any drug for the pre-diabetes except the lifestyle changes. But in some individuals, what I told you, all the cluster of these comorbidities, then you can add metformin. See what is our diagnosis here. 0 means fasting. Fasting 120. 120 means 2 hours postprandial, 209. What is our diagnosis? Fast. Impaired glucose tolerance, IGT, or postprandial pre-diabetic. So it's a pre-diabetic, impaired fasting, impaired glucose tolerance. So these impaired glucose tolerance are at high risk of getting the vascular events. So IGT itself is an independent risk factor for the vascular diseases. So now the classification. So the 4 clinical classes, type 1, type 2, gestational and other. Very easy to remember. So classification of diabetes, type 1, type 2, gestational and other types. So type 1 is again 2 types. One immune mediated your GAD65 antibodies will be positive here, and idiopathic. GAD65 antibodies will be negative, but in both the cases, C-peptide levels will be very, very low. So C-peptide means your endogenous insulin production. So lower the C-peptide level means there is no insulin production at all. So insulinopenia or insulinitis. But when the immune mediated, you will get the GAD65 antibodies positive, whereas in idiopathic, those antibodies will be the negative. But 95% of the cases, they are all immune mediated. Very, very few cases are idiopathic. So that is type 1 diabetes. So in the type 1 diabetes, diagnosed by lower C-peptide levels and positive GAD65 antibodies. Type 2 diabetes, more of insulin resistance, no antibodies. C-peptide will be very much elevated because in type 2 diabetes, because of insulin resistance, your pancreas is producing more and more insulin. That is hyperinsulinemia. So C-peptide levels at a higher level. That means your endogenous insulin production is good. But that endogenous insulin production, high insulin production, that is hyperinsulinemia, is not sufficient to match the insulin resistance of that particular person. And then the insulin resistance will be much higher when compared to your insulin production, even though it is very high. Then it gives way to cause more and more hyperglycemia. That is type 2 diabetes. So you will find the markers of insulin resistance in type 2 diabetes. What are they? Acanthocytes nigricans, skin tags, abdominal adiposity, hypertriglyceridemia or dyslipidemia, etc. Gestational diabetes is a very good topic. So we will take the gestational diabetes at a later time in exclusive class on gestational and pre-gestational diabetes. So very, very important topic. Unfortunately, more and more cases of the GDMs are seen nowadays because of the childhood obesity, because of the late marriages, because of the pregnancy at 30 plus, at 35 plus, and the strong family history of the diabetes in the family. So these are the certain reasons to cause a gestational diabetes in the society. And coming to the other specific types, they are also common in Indian population. Monogenic diabetes. So that is your MODY, your maturity onset diabetes in the young. So it's all a defects in the single gene, that is a monogenic, but usually the diabetes is polygenic. Diseases of the exocrine pancreas, they are also very common. You consider as the pancreatic calcification, pancreatic calcified diabetes, calcific pancreatitis, etc. And then there's some drugs, especially your steroid-induced diabetes, post-COVID era, and chemical-induced diabetes. So there are other specific types, and also other types are also there like LADA, latent autoimmune diabetes in adults, and then you have the type 5 diabetes, Alzheimer's diabetes, etc. See, these are the different types of the diabetes seen in the youth. So whenever a fellow aged about 20 years or 25 years or 30 years comes to you with a diabetes, so you have to think all these conditions, all these DDs. It could be type 1 diabetes, provided the person is lean, provided there is a classical 3Ps, provided there is a weight loss. So the lean, weight loss, and classical 3Ps. So most probably, and no family history of diabetes, most probably you are dealing a case of type 1 diabetes in youth. MODY, that runs in the 3 generations, a single gene mutation. The patients are not lean, they are ideal body weight. And then the diagnosis is by your genetic testing, and then the treatment is very easy. A lot of these bodies, they don't require any treatment except your dietary approach and your exercise. And some people may be very much responded to your sulfonylureas. So type 2 diabetes is a big problem. We are seeing every day, tons and tons of the cases are there in the hospitals. So they are the type 2 diabetes. In youth, because of the early onset of the type 2 diabetes. So type 2 diabetes occurring at the age of 18 years, 20 years, 21 years, they are all possible because of the dense calorie diet eating by the students, and then the physical inactivity in the students, and the childhood obesity. Okay, so they are the reasons for your early onset type 2 diabetes in children born to the strong family history of the diabetes. FCPD, yes, a lean fellow, chronic abdominal pain, steatorrhea, and if you have an X-ray abdomen, you can see the calculi in the pancreas against your T12 and the L1. So that is FCPD. Even though the blood sugars are very high, it is not, they don't cause ketosis. So that means ketosis resistant diabetes mellitus in FCPD. Whereas the type 1 diabetes, if the sugars are very high, the ketosis, usually they're prone to the ketosis because there is no insulin at all. Diabetes secondary to the endocrinopathies, like an hypothyroidism causing diabetes, hyperthyroidism causing diabetes, acromegaly, Cushing's, etc. So these are all the different types of the diabetes you see in the youth. So whenever you see a diabetes in the youth, don't think that they are always because of the type 2 diabetes. They are always because of the type 1 diabetes. They could be type 1, type 2, or MODY, or FCPD, or drug induced, or maybe other endocrinopathy associated diabetes, or maybe gestational diabetes. Here the patients are dependent on the exogenous insulin injections for survival and also for health. So in the type 1 diabetes, they need insulin from the day 1 to the day of the death. So insulin, more insulin in type 1 diabetes. So don't give any other drug except intensification of your insulin therapy. Maybe single dose, or maybe 2 doses, maybe 3 doses, maybe 4 doses, etc. So insulin is required for the survival of the patient. If you don't give the insulin in type 1 diabetes, so within 5 days or within 1 week, so they will land up with severe dehydration, Kussmaul's respiration, urine ketone bodies will be positive, pH will be low, etc. And the condition you consider as diabetic ketoacidosis. So it is almost a medical emergency, and left untreated, very high mortality. Epidemiology, luckily less in number, 5 to 10% of all Indians with diabetes have the type 1 diabetes, but in my practice, not even the 5%, maybe 2 to 3% of the type 1 diabetics. Okay, but type 1 diabetes are very common in the Europe countries, like Finland, Netherlands, etc. in the UK. So type 1 diabetes is very high in that conditions. Onset usual in the childhood. Yes, we see the type 1 diabetes at the age of 3 years, 4 years, 6 years, 7 years, etc. And also the adolescents, maybe 14 years, 15 years, etc. But that is also very important. Can occur at any age. So don't think that diabetes occurring at the age of 50 years or 55 years is always type 2 diabetes. It could be type 1 diabetes, provided short history, symptomatic, and unintentional weight loss. I have seen few cases beyond 60 years of age group with polyuria, polyphagia, polydipsia, and unintentional weight loss of 8 kgs, 10 kgs, etc. And you check the urine 4+, not only the urine, ketone body is also positive. So what it means? So that means even though the age is 60+, it's not type 2 diabetes, but it is type 1 diabetes. So how will you differentiate between the type 1 diabetes and type 2 diabetes in the such situation? So send the C-peptide, get the C-peptide, very, very low. Get the GAD65 antibodies, they are the positive. Am I clear? Right. Symptoms, see the abrupt onset of the severe symptom. Always symptomatic. Type 1 diabetes is always symptomatic because polyuria, polyphagia, polydipsia, they are always symptomatic. May present in the diabetic ketosis. This is also very important. Sometimes in the pediatric wards, in the pediatric emergency, they see a lot of dehydration individuals. Yes or no? Dehydration. They immediately ask the mother, any history of the gastroenteritis? If there is no history of the gastroenteritis, if the fellow is having the severe dehydration, always think of DKA. So that means in the pediatric case group, severe dehydration in the absence of gastroenteritis, please think of diabetic ketoacidosis. Get the blood sugar done for 400, 500. Get the urine ketone bodies, they will be the positive. So here the diabetes is the cause for your dehydration. Diabetes is the cause for your dehydration because of the DKA, diabetic ketoacidosis. So give normal saline, give insulin. So that's how you have to treat this patient. But in all the dehydration individuals, don't give the ciprofloxacin, metronidazole, etc., etc. So the cause is very important. The etiology is very important. If it is because of the gastroenteritis, then you can give the antibiotics. If it is not because of the gastroenteritis, definitely you have to see the metabolic cause in them. And most important metabolic cause to cause severe dehydration is diabetes, type 1 diabetes. See, early onset type 2 diabetes along with explosive increase in the overall prevalence of the diabetes. So you all know the numbers, very, very high in type 2 diabetes, explosive numbers. Right now we are having the 12.5 crores, maybe next year, maybe 13.5 crores, maybe another 3 or 4 years, maybe. So this is the early onset of the type 2 diabetes. This is the MODY with mutation in the single gene. Diagnostic criteria for the MODY: Tattersall and Fazans, 75. Age less than the 25 years at onset. This is very important. So diabetes in youth need not be always type 2 or the type 1. Could be MODY. See, autosomal dominant with the 3 generations are involved. 3 maternal generations or 3 paternal generations. Okay. Absence of the ketosis. Check the urine ketone bodies. They will be always absent. So ketosis resistant. Controllable without the insulin, in at least in the early stages of the disease, just with your sulfonylureas. So clinical criteria are no longer valid and genetic analysis is needed to confirm the type. So if you are in a doubt, young individual, less than 25 years, 3 generations, lean, ketosis is negative. So definitely you are thinking it is more in favor of the MODY, but don't be happy at that juncture. Send it for the gene reports. So the one center where they do it is the CMC Vellore. So we send the blood to the CMC Vellore, and after 1 week or the 10 days, we will get the gene report. So whether the patient is a MODY or not MODY. If it is a MODY, which type of the MODY? Is it MODY 1, 2, 3, 4, 5, 6, 7, 8, 9, etc. So usually they are non-obese. They looks like the type 1 diabetes because non-obesity, young individuals, heterogeneous clinical phenotype. They do not need insulin initially. Later they will become the insulin requiring. So it is all because of the HNF1 alpha, that is hepatocyte nuclear factor 1 alpha, or hepatocyte nuclear factor 4 alpha. They are the defects in the type MODY 1 and the 3. See, I told you that there is only mild fasting hyperglycemia. So there is a MODY 2. No treatment is required if it is MODY 2 because only mild fasting hyperglycemia. Diabetes with renal cysts or renal agenesis. So that is in the MODY 5. And definitely there is a DA, DM, OAD, that's diabetes insipidus, diabetes mellitus, optic atrophy, deafness. So this is also very common. So you need not remember all these things, but one thing is very clear. Whenever you see a case of the diabetes in the young individuals, MODY could be one option. And you ask the 3 generations history of the diabetes, and they are the lean, non-obese, and the ketosis resistant. So the urine ketones will be the negative. And then think of MODY because the sugars are not very high, only fasting hyperglycemia. You need not start with the insulin at this juncture. Maybe sulfonylurea is sufficient for them, or no treatment is required. So this is the differences between the monogenic and the early onset of the type 2 diabetes. See, the monogenic or MODY, it is a non-obese, whereas the early onset type 2 diabetes usually overweight or the obese. Monogenic acanthosis nigricans will be absent because there is no insulin resistance in here. Where in MODY early onset type 2 diabetes, insulin resistance will be there. So acanthosis nigricans and skin tags, abdominal adiposity, etc. Here the 3 generations history in the monogenic, where the type 2 diabetes, both the parents are the paternal or the maternal uncles or the aunts, etc. That type of the families will be seen in type 2 diabetes. Monogenic only insulin secretory defect. It is a single gene, where the diabetes is a polygenic. Not only the insulin secretory defect, but more of the insulin resistance there. Monogenic seen in all the populations, where the type 2 diabetes usually with the high prevalence of the type 2 diabetes like India, Pakistan, Sri Lanka, Nepal, China, etc. Asia. Response better to the sulfonylurea, that is the MODY, where the type 2 diabetes. Response better to lifestyle measures, not the metformin. Response better to the lifestyle measures, your yoga, your exercise, and then the metformin. And then maybe SGLT inhibitor, maybe the gliptins. Now the treatment is individualized, not glucose-centric. Okay, so you can start any drug of your choice from the day 1 in type 2 diabetes, provided if the patient requires it. For example, the patient is at risk of heart failure. You are diagnosing the diabetes today. So what is your drug of choice? SGLT inhibitors. Okay, so the fellow is at risk of getting the hypoglycemia, a newly diagnosed diabetes. So what is your choice? Not the sulfonylureas, not the insulin. Okay, so don't use the hypoglycemic agents in them. Maybe metformin, maybe the gliptins, maybe the SGLT inhibitors. So like that. Suppose if the patient is at risk of CKD, so what is your drug of choice? Again, SGLT inhibitors. Suppose the patient is at risk of atherosclerotic cardiovascular disease. What is your drug of choice? From the day one, GLP-1 receptor agonists or SGLT inhibitors. These two are cardioprotective drugs. Ever-proved cardioprotective drugs in diabetes are GLP-1 receptor agonists and SGLT2 inhibitors. Name GLP-1 receptor agonists. Yes, semaglutide, liraglutide, dulaglutide, exenatide. In semaglutide, you have the both oral and parenteral. Oral, you have the Rybelsus. Parenteral, you have Wegovy. Okay, recently entered into the market. So these are the differences between the MODY and the type 1 diabetes. Both are lean. Both are lean. But history, no history in the type 1 diabetes, family history, whereas 3 generations family history here. In type 1 diabetes, C-peptide is low or absent because endogenous insulin is 0. Whereas here, there is some amount of the insulin is there. So in C-peptide will be preserved in the MODYs. Antibodies will be positive in type 1 diabetes, so GAD62 antibodies, pancreatic antibodies, insulin antibodies, etc. These antibodies will be absent in MODY. MODY responds to the sulfurias and diabetes responds to the type 1 diabetes responds to SGLT inhibitors or GLP or metformin. Which one? Insulin, insulin, insulin. So once you are diagnosing as a type 1 diabetes, you may change the brands of your insulin choice, but not the drugs, OHS. Always insulin, always insulin. So this FCPD is also common in Indian, especially in the Kerala, some parts of Tamil Nadu, and also in our Godavari districts. Patient should be from a tropical country. Yes, we are from the tropical country. Diabetes should be present. Yes, they are the diabetics. The fasting blood sugar 160, 170, postprandial 300. Evidence of chronic pancreatitis should be present. That is the very important. That means you should think that this patient could be a FCPD. FCPD, young individual, youth, tropical country, and features of the chronic pancreatitis. That means a chronic abdominal pain, epigastric region, radiating the back, associated with the vomitings, relieved with some nauseas. Okay. And then if you see the amylase and lipase, they will be elevated, past histories, etc. And most important thing is X-ray abdomen and ultrasound abdomen. X-ray abdomen, you find the calculi against your T12 and L1 vertebra. So that is the place where your pancreas lies. Or your ultrasound abdomen shows the pancreatic is atrophic, or head of the pancreas, or body of the pancreas, or tail of the pancreas, and then the multiple calculi. So they all tell you whether with the ultrasound abdomen or CT abdomen. STEAT1 is very common. Abdominal pancreatic function test, there also. So in FCPD, you will have both exocrine dysfunction as well as endocrine dysfunction. In exocrine dysfunction, they almost behave like your pancreatitis. In endocrine dysfunction, they behave like the diabetes. So in the treatment of the FCPD, you have to add pancreatic enzymes supplementation. Your pangenon, your panlipase, your creon, etc. 10,000, 25,000, etc. So you have to give the pancreatic supplementations also. Otherwise, even though the sugars are under control, if you don't treat the exocrine pancreas here, so the people will have a lot of abdominal pain, colicky abdominal pain, etc., etc. Quality of the life will be compromised. So you should absence of other causes of the chronic pancreatitis. This is very important. In India, 3 causes pancreatitis. One is, most important is alcoholism. So don't indulge in alcoholism. Number 2, gallstone disease. Number 3, triglycerides, hypertriglyceridemia, more than 500. Could be a possible to cause pancreatitis. And of course, other causes like autoimmune, etc. See the calculi here. Do you Appreciate the calculi, a beautiful calculi for the total pancreatic duct. Total pancreatic duct. So on both sides of your spine. So here the lean patient, see the BMI less than 18. So the normal BMI is between 18.5 to 22.9. History of oily stools and the recurrent abdominal pain, absence of ketosis in spite of the high blood glucose. Severe diabetes, fasting will be more than the 200. Multiple pancreatic calculi shown on the X-rays, ultrasound, CT scan, MRI. Pancreatic dilatation may also be seen. Most commonly found in AP, Godavari districts, Kerala, and also Tamil Nadu. Exact etiology is not known. There is a significant increased risk of the pancreatic carcinoma. See, FCPD is not a good diagnosis. The people are not happy, we are not happy because he is having both exocrine dysfunction and endocrine dysfunction. And also the quality of the life also is also very, very low. And unfortunately, most of these people may turn up into having pancreatic carcinoma. What is the marker? Schumann marker for pancreatic carcinoma? CA 19.9. Is it right? LADA, you only can diagnose it. See the salient features of the LADA. Age at onset, more than 30 years, around 30, 35, 36, 40, etc. Positive for at least one of the autoantibodies as well as the type 1 diabetes. So GAD65 antibodies will be the positive. Who should advise? Antibodies. You should advise. Okay? To know whether the fellow is having autoantibodies positivity or not. So when you will advise, when you think of it, when you postulate it could be a case of the TODA, then only advise GAD65. Otherwise, you diagnose type 2 diabetes, you don't advise. So usually in that way, we miss. We see a lot of the cases. Earlier diagnosis of the type 2 diabetes, then we see it is a case of LADA. See why the difference? See, free from insulin treatment for the first 6 months after the diagnosis. You don't require insulin in the first 6 months of the diagnosis of the life. You almost treat like the type 2 diabetes. But will require insulin treatment much earlier in the course of the disease than the type 2 diabetes. Type 2 diabetes also they require insulin. When? Maybe after 15 years, at 20 years, at 25 years. Because at the time of the diagnosis of the type 2 diabetes, 50% of the beta cell have lost its function. A remaining 50% also, every year, they lose the potency by about 3 to 5%. So what will happen after 15 years or 20 years of the diabetic life? They will be having only 5% or 10% or 15% of the pancreas. Okay. So definitely they need some amount of the insulin at that juncture. Maybe your basal insulin, your Lantus or your Tresiba, etc. But here, within the 6 months, they need insulin therapy. That is LADA. So first 6 months, they almost looks like the type 2 diabetes. You advise lifestyle measures. You give metformin or you give SGLT inhibitors, etc. So the sugars are under control. Up to 6 months or maybe 9 months, maybe 1 year. After that, in spite of your increase in the dosage of your OHS, the sugars also will go up, like your Somogyi phenomenon. Okay. So what you mean by Somogyi phenomenon? Fasting blood sugar will be very high. Then what you do? Your basal insulin increase the dose. Okay, to reduce your fasting hyperglycemia. But as you are increasing more and more fasting, more and more basal insulin at the bedtime, you are causing more and more hypoglycemia at the 3 a.m. And that 3 a.m. hypoglycemia will causing hyperglycemia. So rebound hyperglycemia or post hypoglycemic hyperglycemia. So that is Somogyi phenomena. So what is the management? You reduce the dose of the basal insulin. Don't introduce the hypoglycemia at 3 a.m. So no hypoglycemia at 3 a.m. Then no counter-regulatory hormones. Then your fasting blood sugar will come down. Okay. So the same thing happens in the LADA also. So in spite of increasing your OHS, etc., the blood sugars will go up. Then you should think of it. Why not? It's a case of LADA. Okay. So then immediately you send what drug? What test you send? GAD65 antibody. GAD65 antibody. That will be the positive. Then your diagnosis is clear. So it is autoimmune disease, but it is a slow onset autoimmune disease. That is called latent autoimmune disease. Type 1 diabetes is very aggressive, very fast. Whereas in LADA, very slow, very slow. So these patients are usually lean. They have poor beta cell function as assessed by the C-peptide assay. So get the C-peptide done, that also very low. Get the GAD-6 that will be the positive. Now the diagnosis, revised diagnosis is LADA. And write it on the paper. The diagnosis is LADA. Don't use OHS. Always use insulin. It almost looks like type 1 diabetes. So that you should stamp it. Now this case. 9-year-old boy presents to you with the complaints of the polyuria, polydipsia, polyphagia, tiredness, abdominal pain, and burning micturition. Fasting 208, postprandial 300 plus, HbA1c 10 plus. What is the working diagnosis? What is the working diagnosis? Type 1 diabetes. Is a diabetic, no? Yes, on type 1 diabetes. So what are the points to say it is a type 1 diabetes? Okay, age is 9 years, good. Symptomatic of polyuria, polydipsia, polyphagia, yes. Why he got the abdominal pain? Because of the burning micturition. Why burning micturition? Because of the urinary tract infection. Urinary tract infection, ascending urinary tract infection, pyelonephritis, that could be the one cause for your abdominal pain. And other causes, even your diabetic ketoacidosis also cause abdominal pain. Acute abdomen. What is important metabolic cause for acute abdomen? Good, DKA. Not all acute abdomens are surgical conditions. Sometimes it could be a medical also. As simple as your DKA. Okay. So what further history would you elicit? What further history? Any family history? Suppose if they say the family history is positive, is it type 1 diabetes? Could be type 1 or could be type 2. See, there are some clinches. Suppose they didn't give the weight of the individual. Suppose this boy is overweight. Is it type 1 diabetes or type 2 diabetes? Could be type 2 also. Could be type 2 also. Suppose 3 generations of the families are there are diabetics. Could be MODY. See this abdominal pain. If you ask the history of the steatorrhea, that is also positive. So it could be FCPT also. So that is the very important. That type of the thinking you should develop. So don't jump into a single entity at this juncture unless you have other features also. So you need to understand, you need to ask more and more questions in the history and also in the examination and also in the investigations. Then only you can come to a reasonable test. Suppose here C-peptide levels are very much elevated. Is it type 1 diabetes? Here the GAD65 antibodies are negative in this boy. Is it type 1 diabetes? So how can you say it is a type 1 diabetes? Could be type 1 diabetes. Am I clear? Type 1 diabetes and could be type 1 diabetes are different. Type 1 diabetes means insulin. How long? Life. It could be type 2 diabetes, totally different. No insulin at all. Only lifestyle measures. Your OHS, insulin may be required in the emergencies only. Maybe DKA or maybe acute myocardial infarction, maybe sepsis, etc. Again, come back to the OHS, the quality of the life. See. So this is very important. So what further history? These are all the histories required. What further other investigations would you like to say it's a type 1 diabetes? Good. C-peptide, your GAD65 antibodies, and then your ketone bodies, urine ketone bodies, etc. So then you can clinch the diagnosis. Of course, take an X-ray done to rule out the FCPD. That is a normal, no calculator. Okay, if ask history of the 3 generations, no history of the diabetes in 3 generations, ruled out the MODY, etc. So all these conditions you should think of it. So don't jump to the directly as a type 1 diabetes or type 2 diabetes, etc. C is not known to have the diabetes previously, no past history of the diabetes and no family history of the diabetes. So more in favor of type 1 diabetes at this juncture, more in favor of type 1 diabetes. See the weight, 19.6 kgs, BMI 12.5. That means very lean. So more in favor of type 1 or type 2? Type 1, okay. No markers of insulin resistance. Again, more in favor of type 1. So dehydration is present. So mostly DKA also. What investigations will you ask for that at this juncture when the dehydration is there? ABC, ABC, your pH, your bicarbonate, and urine ketone bodies, etc. See the fasting, postprandial, HbA1c, ketosis is positive. Beta hydroxybutyrate was elevated. What is that? Ketone bodies. So 3 ketone bodies: acetone, acetate, beta hydroxybutyric acid. So lipid profiles: high triglycerides. Why high triglycerides? In controlled diabetes, you will have, so there will be lipolysis. When there is no insulin, lipolysis. When good insulin, lipogenesis. When there is no insulin, proteolysis. So that means breakdown of the protein, then the muscle loss, then your weight loss, etc. Here the C-peptide. Low or high? Very, very low. So absent pancreatic beta cell reserve. For GAD antibodies? Positive. Now what is your diagnosis? That's how you have to come to the type 1. As a postgraduate, you have to cultivate these investigations. So at this juncture, don't jump over to the type 1 diabetes. See next. So get all these done. Ask, see the markers of insulin resistance. There are the not. Whether dehydration is there or the not. Whatever the BMI. Then get the urine ketone bodies positive. Okay. Then get the C-peptide. Then the GAD antibodies. And then club all these figures. Then your diagnosis, type 1 diabetes. In Rajahmundry, in America, in Canada, in Sri Lanka, type 1 only. This case. Here the management, you all know. What is the management? What is the first drug to be prescribed in the DKA? First drug. Fluids. Don't jump over to the insulin. First normal saline. So plenty of the normal saline. Okay, maybe 1 liter in the first 1 hour. Maybe 1 liter in the next 2 hours. Maybe 1 liter in the next 3 hours or 4 hours. Get that. But always respect the urine output. Always respect the urine output. When there is a good urine output, give good IV fluids. When there is no urine output, you are causing more and more pulmonary edema. And then the people will die because of your rehydration rather than the dehydration. Am I clear? So always whenever you give the high intensity IV fluid therapy, always respect the kidneys. Urine output. Okay. Another case, here the 12-year-old girl, diabetes of 6 months duration. Here the 6 months duration of the diabetes, 12 years. She had been diagnosed with type 1 diabetes and initiated insulin based on the age of the patient. So diabetes history of 6 months, diagnosed the type 1 diabetes. So once the diabetes as a type 1, what is the treatment? Insulin. So she is on insulin therapy. However, glucose has always been under poor control. She doesn't have any symptoms attributed to the diabetes. She is asymptomatic. Fasting nearly 200, postprandial 300 plus, HbA1c nearly 10. 200, 300, 10. She has a strong family history of the diabetes. Age 12 years. So what is the case here? Is it type 1 diabetes? Not looking like. So as a postgraduate, should think of this. So don't jump to the type 1 diabetes just because she is aged about 12 years. She is asymptomatic. A strong family history of the diabetes. Okay. Now how to follow up this case? See the family history. Then the weight. BMI. What is the BMI here? 27. Earlier case BMI 17. Here 27. That means overweight or obese? Obese. And the lipid profile, LFT, hemogram, they are normal. Abdominal X-ray, ultrasound, normal. So ruled out your FCPD. Eye examination, normal. No evidence of diabetic retinopathy. No microalbuminuria. No evidence of neuropathy. On examination, acanthosis nigricans on the neck. What it means? Insulin resistance. Insulin resistance. Say 12 years, diabetes, family history, obese, signs of insulin resistance. like your Akathan's nigricans race. So without any further investigations, what is the diagnosis? Type 2 diabetes. Type 2 diabetes. Early onset of the type 2 diabetes. Get the C-peptide elevated. Get the GAD65 antibodies. No. Nil. See the C-peptide. Fairly good pancreatic beta cell result. C-peptide is good. GAD antibodies negative. So what is your diagnosis? It's a type 2 diabetes. Early onset type 2 diabetes. See the difference. In the first case, you have to give the insulin lifelong. Here, stop insulin. Lifestyle measures. Maybe metformin. Plus. So the lifestyle management, diet, physical activity, insulin was withdrawn, started on OHA. Patient continues to do well on the follow-up. See another case. 15 years girl, OPD, recurrent boils on her back. So recurrent skin and subcutaneous infections. Fasting 200, postprandial 300, HbA1c 10. See almost the blood sugars, all the three cases. Fasting around 200, postprandial around 300, and HbA1c around 10%. All the three cases. Earlier two cases, we see one type 1 diabetes, another type 2 diabetes. Now what could be this case? She was detected to have the diabetes at the age of 13 years when evaluating for the urinary tract infections. Okay. She had a strong family history of the diabetes, mother, maternal grandmother, maternal aunts, and also the sisters. Okay, how many generations? 3 generations. What is the next step in the evaluation? Straight away, your C-peptide, your GAD65 antibodies, etc., your X-rays, etc., they are all in the negative, and then send the blood to CMC Vellore for rule out Moody, to rule out monogenic diabetes here. See here, BMI 20, BP normal, all other systemic exams no acanthosis nigricans, no skin tags, etc. So what is your diagnosis? See the chest X was normal, abdominal no evidence, C-peptide normal, fairly good pancreatic beta cell reserve. So what is your diagnosis? It's Modi. What is the treatment? No insulin, not of much OHS, maybe a simple sulfonylurea, maybe your glibenclamide or the glipizide. That's all. No. Another case. 20-year-old male, diabetes of 2 years duration, complaints of recurrent abdominal pain, passing oily stools on and off. So this is the beauty of the history taking. At this juncture itself, you can tell what is the diagnosis. What is the diagnosis? Good. How you come to the reasonable diagnosis? Because of the, so that is, you have to cultivate the habit of taking very good history. History, by history itself, you should diagnose nearly 80% of the cases. Your clinical examination tell you in another 10 to 15%. Your investigations only for 5%. So as a good physician, by history and and examination, you should come to a reasonable diagnosis in about 90 to 95% of the cases. Okay. So don't underestimate the value of history and the clinical examination. Evergreen. History and clinical examination evergreen. See, he has no family history of the diabetes. Here, he doesn't smoke or consume alcohol. He has been on oral anti-diabetic. He must be not from Godavari districts. He has been on oral anti-diabetic drugs since diagnosis, but control has always been the poor. Fasting 200 plus, postprandial nearly 400, HbA1c 10.2%. How will you proceed further? X-ray abdomen, ultrasound abdomen. Bus. See the X-ray. Are you appreciating the calculi? Yes. Showed a large multiple pancreatic calculi at the level of T2 to T12 to L1. So what's the diagnosis? Fibrocalculous pancreatic diabetes. So what prescription you give here? Both good, exocrine and endocrine functions. So management, Started an incident because of the high blood sugars, pancreatic enzyme supplementations, maybe 10,000 units thrice daily. Put on 2000 calorie diet because very lean, losing weight. His next visit, fasting is 95, PP is 180, HbA1c 7.2, and patient is doing well and follow. It's the best slide of today's talk. See the 5 cases, all the 4 cases. See the age of these individuals. See the fasting. See the postprandial. See the HbA1c. So don't diagnose any case just by seeing the noting the age, fasting blood sugar, PP blood sugar, HbA1c. Unless you see holistic approach, unless you see the 360 degrees, the history and the examination and the investigations, you are not able to come to a reasonable diagnosis. See, the treatment varies. Otherwise, all these cases you diagnose as a type 1 diabetes only. So 9 years, type 1, 12 years, type 1, 15 years, type 1, 20 years, type 1. Okay. So this is the very, very important. See, the type 1 is only one case. Other cases, type 2 diabetes, only lifestyle measures. Monogenic, maybe sulfuria, FCPD, both exocrine and endocrine dysfunctions control. So the diabetes in youth is heterogeneous and needs detailed evaluation. So glycosylated hemoglobin, you know that. Clinical values. See, it is an index of the long-term glucose control, HbA1c. This is a very, very important investigation. My favorite investigation in all the diabetes. Okay, HbA1c. So I don't see once in 10 days or once in 15 days. I see only once in 3 months or once in 6 months, maybe once in a year or maybe once in 2 years. So those people moving to Dubai, Kuwait, etc., once in 2 years. Maybe in the same district also I see only once in 3 months or once in 6 months, only with the HbA1c report. So it tells you the long-term control of the diabetes. Okay. See, the test results are not affected by time of the day. We can give at any time HbA1c. Meal intake, whether the pre-meal or post-meal, etc. Pre-exercise or post-exercise or during exercise, you can give the blood. Just administer diabetic drugs. And emotional stress, no role in HbA1c except your immediate blood sugars. Patient cooperation is not needed. So HbA1c is an index of the glycemic control over the preceding 3 to 4 months, depending on the lifespan of the RBC. So these are the methods of the estimation. The golden method is the HPLC method. So that is an instrument costing about the 10 lakhs rupees. So they give only HbA1c reports. Okay, that is the HPLC method. It is the gold standard. Very few centers are having these machines, HPLC. Conditions causing falsely high and low HbA1c levels. Inappropriately low HbA1c levels in hemolysis, hemoglobinopathies, recent blood transfusions, acute blood loss, hypertriglyceridemia, and chronic liver diseases. Because here the lifespan of the RBC is very much reduced. So that is the reason you will get low HbA1c levels in all the hemoglobinopathies, hemolytic anemias, post-transfusions, etc. High HbA1c levels when you will get in iron deficiency anemia, vitamin B12 deficiency anemia, severe alcoholism. See the hemoglobin in alcoholic individuals, 14, 15, 16, 18 also. Okay. Uremia and certain drugs. So these two are very important. So in hemoglobin, etc., there will be apparently low HbA1c levels, whereas in iron deficiency anemia, B12 deficiency anemia, and severe alcoholics, the HbA1c levels at a higher level when compared to the normal. So these are all the targets. Everyone says less than 7%, less than 6.5, 6.5, etc. So normal values in the non-diabetic population is not well defined. For the diagnosis of the diabetes, earlier HbA1c was not included as a diagnostic marker of your diabetes. So earlier only fasting blood sugar, PP blood sugar, and random blood sugar. Now HbA1c is also included as a diagnostic marker for your diabetes. So you know when it is more than 6.5 or definitely is a diabetic. Less than 5.7 is the normal. 5.7 to 6.4 is pre-diabetic. So C-peptide, your endogenous insulin production. You know what you mean by the C-peptide is a connecting peptide. You have the A chain and the B chain amino acids, your insulin molecule, and both A and B chains are connected with your C peptide. And estimation of the insulin is very difficult, whereas estimation of the C peptide is very easy. So for a given C peptide, there is always one insulin molecule. So if you get the C peptide levels, if there are C peptides are 50, how many insulin molecules are there? 50. If the C peptide is 0, how many insulin molecules are there? 0. So indirectly you can know whether the patient is having an endogenous insulin production or not with the C peptide levels. So in type 2 diabetes, what will happen to your insulin levels? High, hyperinsulinemia. So the C peptide will be very high. In type 1 diabetes, what will happen to your insulin levels? Low, 0. So C peptide also will be very low and 0. That is the C peptide, connecting peptide. So the same channel. So the red one is the C peptide, and yellow, two yellows are your A chain and the B chain. So this is the monitoring during the diabetes individuals at the first visit. So don't be happy with the fasting PP and HbA1c in the OPs. On the first visit itself, in all the type 2 diabetes, get all the investigations done to rule out fatty liver, to include your neuropathy or nephropathy or your retinopathy, etc. Because 50% of the diabetes, they present with the complications at the time of the diagnosis itself. But most of these complications are asymptomatic. Don't expect the symptomatic complications. When the fellow is symptomatic complication, they need interventions. When a diabetic presents with a chest pain, breathlessness, so what is the diagnosis? Could be acute coronary syndrome. So get an ECG done, get the troponin levels, and then plan for the primary PTCA, and then go 1 or 2 or immediately have sent for the CABG, etc. etc. So don't invite complications in the diabetic individuals. So give the cardioprotective drugs in high risk individuals. So you know what are all the risks for your vascular diseases. What are the 5 major risks for the vascular diseases? Diabetes, hypertension, obesity, dyslipidemia, smoking. Okay, so in all the diabetics, no smoke, sugars under control, BP under control, lipids under control, body weight under control, and good physical activity. So you are giving good vascular protection. So there you can't invite any vascular events in such individuals, except in very few individuals where even though all these are the negative, still some people will get the massive myocardial infarction because of the genetic origin. Because cardiac problems also runs in the genes. But usually 95 to 97% of the people who can avoid the major cardiac events or the vascular events by protecting all these things. And also you have the emerging risk factors as far as the vascular disease are concerned, like your hyperuricemia, uric acid levels, maybe the gout. Not only the gout, more uric acid means more vascular deaths. Microalbuminuria, the risk factor for your nephropathy, but also for your vasculopathy. And then homocystinemia, again more risk for the vascular disease. So use folic acid, simple folic acid invented by Allapragad Subbarao garu. So that reduces your hyperhomocystinemia. And apolipoprotein B, lipoprotein little a, or carotid intermedia thickness, or your simple LVH, or your ankle brachial index more than the 0.9. So definitely these are all the other emerging risk factors for your vascular diseases. So in a nutshell, whenever you see a diabetic sitting in front of you, check for all these things, whether the patient is having the major vascular events or emerging vascular events, whether sugar is under control, whether BP is under control, whether cholesterol is under control, whether he's a smoker or not. So these are all very, very important. Very, very important. Okay. Now, having known something about the diabetes and its background and your insulin and your diagnosis, and then diagnosis diabetes in the young individuals on the day one, whatever the investigations are supposed to do it. Now we'll move on to the management of the diabetes. So these are the 4 pillars. So your role is only one pillar. So that is drugs. All the diabetics, they themselves, they know that the value of the diet, the value of the exercise, the value of the education, and self-monitoring of the blood glucose. So the glucometer, and then the blood glucose estimation, and then the logbook, etc. So these three are very, very important. So these three are from the patient point of view. So our role is to introduce him the good drugs. So even though you give very good drugs to that particular person, if the person is not compliant with the diet, when the fellow is not doing any exercise, when the fellow is not educating about the diabetes and its complications, so it's very, very difficult to avoid the complications in such individuals. So to avoid the long-term complications, to give them a good quality of the life, to make them to live for the 90th birthday or the 100th birthday in all the diabetic individuals. So all the four are very important. Diet restrictions, good physical activity, good education. Education means medical education or diabetic education. Okay, and then the self-monitoring the blood glucose, your glucometer and logbook. So these are very important. At the same time, you people are also important in prescribing good drug therapy. Your metformin, what is the dose to be started, what is the maximum dose to be going, whatever the role of the GFR in upgrading your metformin, and when to start the pioglitazone, when to start the gliptin, when to start the SGLT inhibitors. So do you prefer dapagliflozin or empagliflozin? Do you start with 5 mg or the 10 mg or 25 mg or the 10 mg? Or are you putting the sitagliptin and the dapagliflozin combination? Or sitagliptin plus empagliflozin and the metformin combination? So these are all very, very important decisions to be taken by you people as far as the physician consultation is concerned. Okay, so from tomorrow onwards, you please stress the value of the diet, exercise, and also education in all our diabetic individuals, along with your drugs therapy. So these are the targets. Fasting blood sugar around 100, postponed blood sugar around 150, and HbA1c around 6.5. Very easy to say because they are the normal values. Okay, what is the normal fasting blood sugar? 100. What is the normal postprandial? Less than 140. What is the normal HbA1c? Less than 6.5. Okay, so that's how I tell to my patients. What is the normal fasting? Reach around 100. Maybe 195 or maybe 103 or 104, etc. Whatever the postprandial, around 150. Easy to remember, 100 and 150. Okay, and then HbA1c around 6%. This is most ideal. Maybe 5.9, maybe 6.1, etc. But in elderly individuals, when the lifespan is very short, lot of the comorbidities, living alone, chances of having hypoglycemia, and more severe hypoglycemia. So definitely you have to keep the targets at a relaxed level. Fasting blood sugar may be around 140. Postpone blood sugar may be around 250 or 300. And sorry, not 300, maybe 250. And HbA1c at 7 or 7.5 also. So in such maybe 80 plus individual living alone with diabetes, hypertension, post-CABD, post-CABG, and also now having the creatinine level 2.5, the 3, etc. So in such individuals, you relax the values. Otherwise, if you keep the fasting around 100, around 150 or HB 6.5, you're inviting hypoglycemia. So once they get the hypoglycemia, so they don't have any adrenergic symptoms in such individuals. So that hypoglycemia is a neuroglycopenic hypoglycemia. So in a neuroglycopenic hypoglycemia, they will get the convulsions, they will get the froth in the mouth, and they will be unconscious and they die. So they initiate the cardiac arrhythmias, tachyarrhythmias, etc., and they may die. So when the other fellow sees the patient is full of sweating, etc., they thought that it is of massive myocardial infarction. But it's not the massive myocardial infarction, but this is because of the death is because of the massive hypoglycemia induced by you people by strictly adhering to the HbA1c around 6 or 6.5 in those elderly individuals. So this is how you have to keep the values in those. So all these targets are individualized. So diabetes means individualized. No two people should be given a single drug or same drug, etc., etc. Both are different depending on the several factors. What about the diet? So now definition of diet now is MNT. What is MNT? Medical nutrition therapy. Therapy means treatment. So diet itself is a big treatment that you should remember, that you should understand. So don't underestimate the value of the diet. Like your drug therapy, this is also therapy. This is medical nutrition therapy. Nutrition therapy. So you should also behave like a dietitian or a nutrition for all your diabetic individuals. So what is the amount of the carbohydrate they should take? What is the amount of the protein they should take? What is the amount of the protein, fat they should take? What about the saturated fats? What about the unsaturated, polyunsaturated? What about the fiber, salt, sugar, coconut water, etc., etc. Or ghee, amount of the ghee. What about the oil? Is it olive oil or sunflower or safflower, etc.? So all these things you should remember, whether it's a vegetarian protein or the non-vegetarian protein. Whatever the volume of the legumes, whatever the fresh fruits, what are the free foods, what are the sweeteners. So these are all very, very, very important for all of you, because MNT is very much required for all the diabetic individuals. Some people, you can reduce the blood sugars with MNT alone. Some people, you can escape the drugs, but everyone should require MNT. So which one is much popular, MNT or drug therapy? Popular is drug therapy, unpopular is MNT. But which one is more important for a diabetic individual? MNT is very important. That you should know. Okay. So this is the components of the dietary management. Restrict the total calories. So every day we are taking about 3000 calories, 2500 calories, etc. Restrict that. Restrict to about 1400 calories, 1800 calories, or less than the 2000 calories, depending on our activity. Quantify the quality of the carbohydrates. So rice, polished rice, so Ricevaria rice, Lalita rice, etc. Very polished rice. Okay, they contain high glycemic index. Instead of them, you take the brown rice, take the quinoa. So they contain low glycemic index. So that's how you have to quantify the carbohydrates. Take less carbohydrates. Take complex carbohydrates. Avoid simple carbohydrates. Avoid fasting and the feasting. Both are dangerous. Both are not advisable for the diabetic individuals. Modify the fat intake. Saturated 7%, polyunsaturated 7%, monounsaturated 7%. So that means around 21 to 25% is the total fats. But consider the saturated fats. They should not be more than 7% of the saturated fats. Okay. Spacing of the meals. This is very, very important. So at least four times meals or 5 times, etc. That means breakfast or the lunch or the dinner or the snacks, etc. Spacing is very, very important. Protein. Unfortunately, Indians, they take very less protein in our diets. So actual protein content is about 1 gram per kg body weight. But most of us, we take only 0.6 or 0.7 grams per kg. So high protein is very much needed for all the diabetic individuals. Fiber, again, we should consume at least 1400 grams of the fiber per 1000 calorie diet. But unfortunately, we are taking only 400, 500. So fiber, high fiber diet. So rich with your vegetables. Continuing the education and the counseling. So this is also very important. So that is how you can control the sugars, you can control the lipids, and also the weight, body weight, obesity. So the diet means not only for the control of your blood sugars, that also helps to reduce your lipids, reduce your blood pressure, and also reduce your body weight. So this is a very important treatment, is the medical nutrition therapy. See the MNT interventions, reduction of the HbA1c of 0.5 to 2.6%. The average of 1 to 2% HbA1c. Which drugs will reduce this much? Tell me the drugs, OHS, which reduce the HbA1c by 1 to 2%. Sulfurias, 1.5 to 2%. Metformin, 1.5 to 2%. No drug will reduce the HbA1c beyond 2%. But here, 2.6% also. What is that? Medical nutrition therapy. So don't underestimate the medical nutrition therapy in diabetes. Whether you are writing the glimepiride or the dapagliflozin or the sitagliptin or empagliflozin, all these drugs, maximum reduction is 1.5 to 2%. But with the good medical nutrition therapy, with the good understanding of your carbohydrates, protein, fat, fiber, etc., you can reduce the HbA1c by 2.6% maximum. So that is the importance of the MNT. Which drug will reduce the HbA1c beyond 2.6%. Insulin is infinite. Even though the HbA1c is 16%, 18%, 19%, give shot, 2 shots, 3 shots, 4 shots, 5 shots, fat. HbA1c will come down to 7, 6.5, or 8, etc. So the maximum HbA1c reduction will be seen with insulin. That is the number one. Number two is MNT. That you should remember in your cortex, frontal cortex. Okay. So next to the insulin, the most important thing is medical nutrition therapy. So don't underestimate the value of the medical nutrition therapy. Then only your drugs. This is another case. Female 55-year-old homemaker, very tough job, had diabetes for 15 years, and her diabetes is under poor control with A1C of 8.8%. 153 centimeters tall and weighs 74 kgs. She does 20 minutes of brisk walking per day. What are the points to consider when planning a diet for her? So what is the working diagnosis at this juncture? Okay, type 2 diabetes, 15 years, 55 years old, poor control with HbA1c, 8.8%. Is she obese? Ideal body weight, 153 minus 100. Height in centimeters minus 100 is your ideal weight in kgs. So 53 kgs is the ideal weight for her. But now she is 74 kgs. So she is obese. She does 20 minutes of brisk walking per day. Now give him a lot of talk on your medical nutrition therapy. Again, the role of improving the walk, brisk walk, to maybe 40 minutes or maybe 60 minutes a day. So 20 minutes morning or 20 minutes evening or 30 minutes morning, 30 minutes evening, etc. And then role of the diet, because she is about 18 to 20 kgs more than the ideal body weight. So the diet to reduce the body weight, the diet to reduce the blood sugars also. So this is the very important. So the medical nutrition therapy is very important here. Steps to the dietary intervention. Assessment of the calories. How many calories you require? Anthropometric measurements. What is your BMI, your waist circumference, etc. Calculation of the calories. How to calculate the calories, about the carbohydrates, proteins, fats, etc. Making a meal plan, and then the follow-up. This is very important. Follow-up is very important. So it's not a 1 month or the 2 months or the 3 months. It must be a repetitive. It must be an aggressive. It must be a progressive. It must be a dynamic. So aggressive, dynamic, progressive follow-up must be there in all these individuals. So this is your overweight, normal and underweight. Sedentary, we are all comes under sedentary or moderate. So underweight 35, normal 30, overweight or obese 20 to 25. Suppose if you are overweight, so how many calories you require? 20 to 25 calories. If you are normal body weight, you require 30 calories per kg body weight. And if you are underweight, no one is underweight here, they require 35 kg. So most of us, we require either 30 or 20 to 25. Carbohydrate is the nutrient with the maximum impact on the blood glucose levels. You all know that if you take the simple sugars, glucose will go up. Complex carbohydrates preferred over the simple ones because they take a lot of the time in the stomach. So there is the gastric delaying time will be there. So absorption will be delayed. So obviously the blood sugars rise will also be reduced. Individual approach is based on the individual eating habits and blood glucose and the lipid goals. So carbohydrates, the diabetes, these are all very important. So yes, glycemic index and the glycemic load. What is the glycemic index? It classifies the foods or the meals based on their potential to raise the blood glucose levels. Their potential to raise the blood glucose levels. But they express it as a percentage of the response to a standard food. So what is the standard food of carbohydrate? Either white bread or pure glucose. So compare the food. You take either rice or the wheat or brinjal, etc., or potato, etc. So how much blood sugar they rise? Compare with either with glucose or with the white bread. That is glycemic index. So these are all the glycemic index of the different foods. What about your rice? 73. Brown rice, little lower, 68. See the soya beans, 16, number 26, serial number 26. Soya beans, very low glycemic index. Okay, what are the foods low in the glycemic index here, less than the 50? Orange, apple, orange, okay, milk, skimmed milk. Then soya beans, yes. Lentils, yes. Chocolate. What are all the foods we eat? They are rich with calories. They are rich with glycemic index. So the more glycemic index means the sugar's rise will be very high. Okay. So please see that the foods low in the glycemic index you should consume in a big way. The foods rich with the glycemic index, high in the glycemic index, have to be avoided. Have to be avoided. Protein is very, very important. Insulin is required for the protein metabolism. Daily protein intake 1 gram per kg body weight. Protein should contribute about 15 to 20% of the total daily calories. How much carbohydrates? 50 to 55% or maximum 60%. Proteins maybe 20% and fats 25%. So here the non-vegetarian and the vegetarian fats. Who is vegetarian? Who is vegan? Vegan ante milk products kuda teeskoru. No milk products. That is the vegans. So the fat is about 30% of the total energy take. I told you the saturated fats, not 10%, should be less than 7% only. Trans fats are best avoided. Your merpakai bhaji, etc. They are all the trans fats. So they put oil at 3 p.m. till night 11 p.m. or 1 a.m. The same oil will continue. Recycling of the oil. They are all trans fats. Very, very dangerous. Very dangerous. Intake of MUFA is to be encouraged. That is monounsaturated fatty acids and polyunsaturated fatty acids. They are very good. So ratio of the omega-3 fatty acids. Rich in fish. Fish. Okay. So fish is very good for health. So these are oils. Which oil is good? No oil is good. Any oil. But it is not the quantity, but it is a quantity is very important. So how much oil is required per adult per month? Anyone? What is the amount of the oil you require per adult per month? Is it 1 liter? Is it 2 liters? Is it 3 liters? Per adult per month. Actually 400 ml per adult per month. Suppose there are 4 members. Ideally in 1 month they should consume only 1.6 liters. But very high amount of the oil we use in the kitchen. So that is another important thing for our early onset of ischemic heart diseases, for the early onset of your diabetes, for early onset of the hypertension, for the early onset of the dyslipidemia. So we should all educate our moms, okay, to reduce the quantity of the oil they consume. Okay. Mustard oil, canola, soya bean, these are all very important. Functional foods, menthulu, menthi seeds, they are very good. They are good. Oats, they are also good. Soya beans, excellent. So these 3 are good. Okay. And free foods. So this you should remember. Again, this is one of the best slides of today's talk. So what foods they can take in? Unlimited amounts. It's a very common question asked by our patients. Okay, what food I should take? You take vegetables. Your cabbage, your cauliflower, vegetables, tomatoes, cucumber, etc. Clear soups. Okay. And then tomato juice, but no sugar. Buttermilk, not lassi. Okay. Lime juice without sugar. So these are the very, very important things. Not your Coca-Cola. Taste the thunder, etc. etc. Okay. Sorry. So which city is having the highest diabetes and ischemic heart disease in the world? Which city is having highest number of the diabetes and ischemic heart disease in the world? Okay, I will give a hint. It is situated in Asia. I am giving another hint. It is situated in India. I am giving another hint. It is situated in Telangana. Hyderabad. Because of three things. Because of the three things. Sweets. Second one is biryani. Third one is bakery. And without biryani. So these three are placing the Hyderabad as the world capital of diabetes and ischemic heart disease. The prevalence of the diabetes in Hyderabad is to the tune of nearly 35%. Very high, very high. See the importance of the diet. So unless you cut down the calories, unless you cut down these types of the foods, it's a very, very difficult. See, these are all the free foods in the diabetes. So sweeteners, we have a lot of the sweeteners. So this is the food. See the beautiful food, colorful food. Okay. So lot of the fruits, lot of the vegetables, then the buttermilk or yogurt. Okay, these are the very important millets, soya beans. So you are not finding here the Coke, you are not finding your bakery, you are not finding your biryani, you are not seeing any sweets here. So these are the foods you should consume. Otherwise, all of you will become the diabetics or the hypertensives or the metabolic syndromes, maybe in the next 1 year, maybe next 5 years or 10 years. So because we are all Indians, so our genes are very, very prone for the metabolic diseases, especially the diabetes, etc. Unless you concentrate on these food habits, it's a very, very difficult to control the diabetes. So intermittent fasting, okay. Keto diets, okay in some individuals. So these are all the again good food. In conclusion, dietary management is not just a diet prescription alone. You remember by this time. Okay. So it's a very, very important dietary prescription. It's a personalized diet plan to suit the lifestyle of the patient rather than demanding a change in the lifestyle to suit the diet plan. Newer trends and concepts like glycemic index, glycemic load need to be incorporated in the comprehensive management of the diabetes. Successful dietary therapy is a team effort. So your mom should say okay, your father should say okay, your better off should say okay, your children should say okay. These are all very, very important. So almost like a, and also your friends. Thank you. Thank you all for your sparing your valuable time.